All right, this is the July 2025 MEC Minute, and actually, we are going to talk about sudden ambulance death syndrome, and this is the first of two videos that's part of this MEC Minute. So I'm going to do a quick review of sudden ambulance death syndrome, and then there is going to be a link for a second video that goes to Dr. Innes, who is an EMS medical director out of the University of Buffalo, and she has a great talk on this subject. Her talk is a couple years old, so some of it may seem a little dated when she talks about COVID. She gets a little bit of local specifics, but I think it's a great introduction to the topic. And the reason we're talking about this is because we're going to develop a protocol regarding sudden ambulance death syndrome for our 2026 protocol rollout. So what is sudden ambulance death syndrome, or SADS? And this is from an EMS physician, and from her perspective, SADS is when a critically ill patient who deteriorates quickly in the back of or on the way to your ambulance. So these patients, we need to really focus on stabilizing before we move them into the truck and start moving. So one of the things I like to start with is this is a poster session presented at one of the National Association of EMS Physicians meetings, and it's based on a review of data in ESO. ESO has a lot of data, and they have a statistician, Dr. Emily Crow, who actually earned her PhD while working up at the National Registry, and they analyzed patients who died shortly after EMS arrival or went into cardiac arrest. And they looked at some inclusion criteria that had to do with O2 sat of less than 90, mean arterial pressure of less than 60, which is a patient who is in shock, a respiratory rate that's either 4 to 8 breaths per minute or over 28, and a heart rate that's less than 50 or over 150. And when they looked at all of that, they went on to see that vital signs that were associated with increased incidence of arrest immediately or shortly after EMS arrival was an O2 sat of less than 90, a respiratory rate that was low, and a heart rate that was low. And if you look at these patients, for every minute of delay in EMS in terms of recognizing the patient was in trouble and instituting treatment, there was a 4.4% increase in the risk of cardiac arrest while under the care of EMS providers. So what this says is we should be paying attention to the patients, and rather than swoop and scoop, we should spend time to stabilize the patient who has evidence of medical illness that results in clinical deterioration. A lot of times we think about just getting in the truck and going. That probably is what we're going to continue to do with trauma patients, but for medical patients, it's going to be stay and stabilize, spend 5 or 10 minutes on scene. It's really no difference than the focus we have on stabilizing a patient who needs to be intubated before we give them a paralytic and intubate. So the experience is to focus on the patient and provide stabilizing therapy. How about some additional information that would support this? Well, the MedStar Group ambulance company out of the Fort Worth area did a review, and they had 30 cases that they reviewed. And if they look at those cases, almost half of these patients had respiratory symptoms that resulted in their patients suffering a cardiac arrest. About 27% of the patients had cardiac issues, and then about a fourth of the patients who had medical etiology of cardiac arrest had some other cause. If you look at this, also, about 17% of the patients had, of this population of 30 patients, had an O2 sat of better than 90%. And if you look at these patients, they actually deteriorated, and they were down to 10% before they started to move it. To move the patient. So they failed to recognize and manage the patient. And about 3/4 of these patients had delays in providing ventilatory support. Again, if you look at these numbers, half the patients had respiratory issues that led up to them suffering a cardiac arrest. Well, Dr. Innes is from Buffalo. What is some of her experience suggestions? She'll go into more detail in her talk. For Buffalo, about 10% of the arrests that the EMS providers managed, 10% of those arrests were from patients that arrested while in EMS care. In other words, they were not in arrest before EMS arrived. And if you look at these patients who went into arrest, what was the one thing One intervention that was the least likely to be done for these patients before they went to arrest, vital signs. We harp on vital signs, do them once, do them twice, do them three times. The single biggest deficiency in care of these patients who went into cardiac arrest, and we're talking about cardiac arrest while in the care of EMS, was lack of vital signs. The most common initial intervention for these patients was to move them. So they didn't get vital signs, and they instituted movement before vital signs were done or care was provided to stabilize the patient. And in Buffalo, the patient's likelihood of survival was dependent on how quickly intervention was provided. So patients who had early intervention had about an 18% chance of survival versus those who had later intervention where it was about 9%. And when I say later intervention, it means more than 10 minutes after, or they didn't have any real intervention until the patient arrested. So Buffalo experience suggests if the patient's unstable, you need to stay there. You need to provide stabilizing treatment. But also, if you look at what helps the patient, simple maneuvers that respiratory support, like a BVM, make a difference. Well, some people have taken this further, and Pittsburgh is a great example. So in Pittsburgh, they have a bundle of care. And this bundle of care has contributed to a algorithm for treatment of unstable patients in the state of Pennsylvania. And we'll talk about that in a minute because it's going to be something we use as we develop our protocol for next year. So Pittsburgh's bundle of care is no movement of the patient until care objectives have been completed, which we're going to institute monitoring. We're going to aggressively manage the airway, either via basic or advanced methods. There's nothing wrong with using a BVM with an oral airway or a nasopharyngeal airway to stabilize the patient. This does not mean you have to intubate the patient within the first couple of minutes. Aggressive management of respiratory therapy, respiratory distress or failure has to be also completed. And that could be, again, CPAP, positive pressure ventilation, or BVM. Early access, either IV or IO, with aggressive management of hypotension with either IV fluids or vasopressors or both. For us, we use epinephrine. We probably should be using it more for our unstable patients. And there has to be maximal medication therapy based on the patient's underlying pathology before the patient starts to move. These are things we should be able to accomplish in 5 to 10 minutes. And honestly, we may need to adjust our practice model from taking them down 3 flights of stairs into the truck before we start treatment to we take our stuff up when we get to the patient and we initiate care where the patient is. And in the Pittsburgh experience, the rate of EMS witnessed arrest went from 12% of all cardiac arrests managed by EMS down to 5.8 or 6%. So they essentially reduced the patient's risk of dying or going into cardiac arrest while under EMS care by half if EMS started early therapy to the medically unstable patient. Now that I've said that, we can think about what are we going to do. And I'm starting to warn folks when I show up at the stations. We're going to have a dichotomy of care in 2026. Trauma arrests, trauma patients who are unstable. We are going to focus on life-saving interventions and immediate transport. We will focus or talk more about that later in the year. But when I say life-saving interventions, it's going to be stop the bleeding, decompress the chest if you're concerned about tension. If the patient needs a crike because it's your only uh, reasonable means of managing the airway, then they get the crike. Everything else is done as you're moving the patient. Maybe you start a BVM at the scene, but you quickly get the patient in the truck. You worry about an advanced airway later on. You worry about PXA, IV fluids, anything else as the truck is moving. Again, we'll talk about that later. So that's one thought. On the opposite side of the spectrum, unstable medical patients, we're going to stabilize on scene before transport. We're going to spend time evaluating the patient, providing immediate needs such as oxygen, CPAP, BiPAP, BVM, pressors or fluids, management of cardiac arrhythmias if they're life-threatening before the truck starts. Before we package the truck and start package the patient in the truck and start moving. So here's the algorithm that I alluded to. This is out of Pennsylvania, and I know it's crowded, but we're looking at, stay and play. We're going to identify the patients who are at risk We're going to do vital signs. We're going to manage their hypoxia. We're going to manage their respiratory depression. We're going to manage their arrhythmias. We're going to start fluids or pressors or both if they're needed for blood pressure and so on. So this is the approach we're taking, and you're going to hear more about it both in Dr. Innes's talk after this one, as well as the protocol rollout for next year. So I talked about Dr. Innes. There will be a video. This is her talk on high flow diesel fixes everything and other lies they told us in paramedic school. Dr. Innes is a past paramedic. She worked the street. She went to medical school and did emergency medicine residency and a fellowship in EMS. She's an EMS medical director in the Buffalo area. When you look at the links in EMS1, there'll be a second link for her talk. Please take that link and view the video. It's about 20 minutes, and I think it's very educational. For the post-test, you have to view her video to get some of the answers. So please take a look at it and review the video. Finally, really want your feedback on this subject. So after you've viewed this video and that of Dr. Innes, please, if you have comments, questions, concerns, please post them on Ask a Doc on Basecamp. So that's what I have for my portion of the July MEC Minute. After this video, please step over, take the link to Dr. Innes's talk. Thank you.